Hello, everyone, and welcome to the Research Brown Bag, our first brown bag of 2022. It's starting off a little differently than we had all hoped, I think. Today we have Joe Lewnard to talk to us about why it's starting off so differently with respect to the pandemic. So I will hand it over to Joe.
Thank you, and thanks for organizing and adapting the session as things change, because I know that's no small task to stay on top of. So I'll be sharing a brief slideshow today, and I invite questions in real time rather than waiting to the end. I'd rather clarify something, when the data are present rather than trace back. So please feel free to ask questions anytime you're so inspired. This is work that I undertook in collaboration with great colleagues at Kaiser Permanente of Southern California, led by Sarah Tartoff, and covers outcomes in the Kaiser Southern California healthcare cohort. It's also in connection with colleagues at CDC in the new forecasting division, and covers clinical outcomes among patients who were infected with the Omicron variant during the initial emergence of this variant over the month of December. So briefly, a note on who's included in this study, which is a descriptive study. We are looking at cases who were tested for SARS-CoV-2 infection and found to be infected within Kaiser Permanente of Southern California, which is a large healthcare provider covering about 5 million residents of Southern California, or 19% of the total population of the region. And we're looking at cases who were diagnosed from 30th of November to the end of December 2021, which is when Omicron really emerged and overtook Delta as the dominant circulating infection in California. In terms of the diagnosis, we're looking at people who were tested using the Thermo Fisher TAC path, which is the main assay used for all PCR testing in Kaiser SoCal, but not necessarily every single test is processed on this. And for those of you who are very familiar with PCR for SARS-CoV-2, you'll know that this is a device that has 3 probes, one of which is for the S gene, and that S gene target failure, but positive reads on the other 2 probes is a strong indicator of Omicron variant infection, since there's a lot of mutation in the S gene particularly. And so this ended up being a really kind of convenient readout that one could have for identifying Omicron infections early without the need for sequencing of every single case. And so we were in a kind of a fortuitous position, since this was the main assay used, to be able to very easily and efficiently call out Omicron infections and distinguish them from Delta infections at the same time. I'll note not all tests at KPSC or Kaiser Permanente SoCal are processed on the TAC path. Specifically, the TAC path is the main device used at regional reference labs that receive all SARS-CoV-2 specimens from outpatient testing. Some hospitals within the Kaiser system have their own in-house assays for SARS-CoV-2 PCR testing, and those are obviously not necessarily getting processed at regional labs and useful for this analysis. So we thought closely about this issue of who's going to be tested, who's going to be available for this study. And since we're looking at outpatients and have the kind of rich opportunity for longitudinal follow-up of people within Kaiser, it made the most sense to do the study by looking at what happens from the point of an outpatient early, if you will, diagnosis forward, rather than comparisons of hospitalized versus non-hospitalized cases, since essentially we can design this at the earliest kind of prospective point in follow-up possible by identifying people who are tested in the outpatient setting and seeing if they go on to require care at higher levels, like in the hospital, in the ICU, et cetera. So our cohort collectively comprises almost 70,000 people who were identified over the month of December as outpatients with SARS-CoV-2 infection, This covers 78% of all positive results in SARS in Kaiser over this period. There are 457 of these people who were tested as inpatients, and I'll discuss them separately and make distinctions throughout this talk about where is the outpatient sample that we're monitoring prospectively versus when are we discussing all admitted inpatients with infection. Just brief note of background, I think this won't be surprising to anybody, but there was very, very, very low rates of S gene target failure here, a proxy for Omicron variant infection through the early part of the December. It was really mid-December that this rapidly overtook Delta and became the dominant circulating lineage. This turned around only in the last 2 weeks in terms of the overall caseloads, but as a current data update is going on right now, has several times more cases to include in all the analyses that are presented here. So very soon there'll be a preprint that you can look at, which describes this a lot more comprehensively than we can with the initial 70,000. Just to note, hospitalizations grew, in connection with the growing load of Omicron cases detected. Brief note on the validity of this definition of the S gene target failure as a way of measuring Omicron variant infection. There are other things, that can potentially lead to S gene target failure. If there's a very, very low abundance of specimen, for instance, and you happen to get a negative probe just, by chance for S gene and a positive read on the others, these turned out to be very rare. So when we looked at the validation sample of about 1,500, just shy of 1,500 cases that were randomly selected for sequencing over this period, we could see that S gene target failure had a 99% predictive accuracy as a basis for calling out an Omicron infection. There were, that's reversed, 99.7% accuracy for calling out a Delta infection if there was no S gene target failure. And if S gene target failure did occur, S gene was not detected, we had 100% of accuracy for calling out Omicron. So I'm going to be using S gene target failure and Omicron and Delta synonymously, because this was a very, very good proxy as it turned out. Brief note also before going into the kind of meat of the analytic findings on who is in this outpatient tested sample, because I think it's really important when we talk about the natural history of SARS-CoV-2, which is what we're comparing in the sample, to say where in the clinical course are we first identifying people and including them in this study. 80% of people tested in the outpatient setting with either Delta or Omicron variant infection had already had new onset acute respiratory symptoms at the point that they were ascertained. So we are looking at a partial point of clinical course in terms of the follow-up that we're doing here from a predominantly already mildly ill sample of people that sought clinical testing and not just, were caught at the very, earliest opportunity through, asymptomatic surveillance testing or something like that. I'm going to come back to this point later because there are some interesting lessons about asymptomatic infections in the cohort. One further note is that among those who were tested in the hospital setting, which is a small sample of 400 something people, there was a very big difference in terms of the proportion that were hospitalized with versus for COVID-19, insofar as when we look at whether there's any record of symptoms occurring on or before the admission date. 97% of those with the Delta infection had a hospital admission that was secondary to symptoms onset, versus 235 of those who were tested and had an Omicron infection, which is only 77% of this group. So in another word, very, very few, if almost no Delta cases here among those tested first in the hospital setting were incidental admissions, whereas almost 25% of those with an Omicron variant infection were essentially only being picked up in the hospital setting because they were being screened. And so this, again, motivates starting to be very precise about what is our definition of a COVID-19 hospitalization going forward. So what we've used as a primary endpoint in this study in terms of a measure of clinical severity is a symptomatic COVID-19 hospitalization, which we're defining here since we're looking at a patient sample that was all positive for SARS-CoV-2 is hospitalization where the admission date is secondary to the first date or that symptoms occurred. So on or after the first date that acute respiratory symptoms were noted. Very clearly, we see the Kaplan Meier curve going up faster and higher for the cases with Delta or no S gene target failure as compared to those with S gene target failure. So Omicron, higher risk with Delta than Omicron. When we look at the endpoint of ICU admission, we see separation as well. Mechanical ventilation, very clear separation. In fact, there were 0 instances of mechanical ventilation among all of the 52,000 people followed with Omicron variant infection. This aligns, very closely for those who have followed animal model studies that show very different kind of attachment in upper respiratory versus lower respiratory epithelia for Omicron versus Delta variant infection. And then last, we saw only 1 death among those with Omicron, as compared to far more among those with Delta. So these simple plots are also designed to accompany a more kind of comprehensive analysis that's accounting for all the various differences that arise in the sample between those who are identified as having Omicron variant versus Delta variant infections. So here, what we're presenting are hazard ratio estimates from Cox proportional hazards models, looking at time to each of the endpoints of interest: hospital admission, symptomatic hospital admission, ICU admission, mechanical ventilation, and death, comparing Omicron and Delta cases. These models control for all the variables that you'd expect could, cause different outcomes for patients. So these include age, sex, the amount of healthcare utilization that these individuals have, and therefore, their propensity to get tested at different points in their clinical course. So this is, across outpatient, inpatient, and emergency department settings in the prior year. Their history of vaccination, both number and type of vaccine received, and I'll be getting into some of the interesting findings about these variables later, just letting you know here that they're adjusted for in these analyses. And then last, their history of known previous infection with COVID-19 during the last 2 years. When we look at the sample that was tested first in the outpatient setting and subsequently followed for whether they go to the hospital, we can see there's about a 50% reduction in their risk of hospital admission and symptomatic hospital admission. These differences are more blurred when we look at all cases and include those who were first tested when they were in the hospital, which makes sense because we're looking at an already hospitalized sample in that case. When we look at events like ICU admission and death, we had so few of them that it's not even possible to do covariate adjustment, insofar as there's a lot of covariates where no events occurred in particular strata. So although that won't be the case with a data update that has hundreds of thousands more cases, it was an important kind of finding in its own right that there were so few in the Omicron group that we couldn't analyze them in an adjusted manner. So here, when we look at those who were first ascertained in an outpatient setting and subsequently followed to identify these events occurring, we saw about a 74% reduction in the risk of ICU admission. Again, no mechanical ventilation events in the Omicron group, and a 91% reduction in risk of death. These findings hold within subgroups that are relevant to consider. So I've outlined some of them on this plot here, although there's more extensive versions in the preprint that's available on medRxiv. When we look within subgroups defined by age, sex, history of prior infection, et cetera, history of vaccination, we can see in each instance, although the confidence intervals are wider in these larger samples, that with the same adjustment for all the other variables that were included in the initial analysis within each of these subgroups, the direction holds of lower risk within the group that was infected with Omicron as compared to Delta variant SARS-CoV-2 infections. There's several points I want to make in particular here for groups of interest. One is those with documented previous infection and those without documented previous infection. It's really important to note that although it would be really nice to control for natural immunity in a true sense, it's impossible insofar as we don't know everyone's infection history, because a lot of infections are never tested, are tested outside of clinical settings using antigen testing or something like that, or might have been ascertained in settings where a diagnosis would not have reached Kaiser. For instance, if they're tested in their workplace, they don't require an insurance reimbursement, and Kaiser has no interaction with this kind of care. So we have a messy group of people without documented previous infection who might be heterogeneously immune. Some of them are probably naturally infected, some of them are not. But among those with documented previous infection, we can say pretty much for sure that they were truly infected if Kaiser at one point had a positive PCR test for these individuals. And this is a finding I want to sort of emphasize in particular, although it's underpowered and there's not a whole lot of people in this group, it's encouraging to see directionally that things still point to low risk in this group, because one of the big worries out there is that Omicron infections look less severe because they're occurring in more immune people. Here we have a stratum of truly somewhat immune people who've had a previous infection, and can see at least directionally in this small group that things still hold in the direction that applies to the rest of the analyses. It also holds in the vaccinated groups. So when we look at people who have 1 dose, 2 doses, et cetera, or 3 doses, or those who were never vaccinated before, although these analyses remain subject to the fact that we can't perfectly control for people's history of infection. You might note and be concerned by the fact that this estimate is a little bit different in the 2-dose group. However, I caution that we shouldn't really be analyzing a 2-dose group in an abstract raw sense like this, because the 2-dose group includes people who've been vaccinated with 2 mRNA doses, receiving the 2nd dose 2 weeks ago, as well as people who've had 10 months of time passed since they received their 2nd dose. And so this is a very heterogeneous group, and in future updates of these data sets will be presenting these stratified by time since 2nd dose receipt, so that we have a more comparable kind of unit of immunity here for these subgroups. I mentioned earlier that it's important to look at data on symptoms, and interesting to follow what happened for people who were asymptomatic, because only part of the story is told by looking from when people have a symptomatic outpatient diagnosis of COVID-19, and 80% of the people in this study are having a symptomatic definition, and what happens after them, since much of what differs about the natural history of SARS-CoV-2 Omicron and Delta variants might actually occur at the earlier part of the clinical course, in terms of whether people go on to have any symptoms or don't have any symptoms at all. So here we have an opportunity to assess this, although not perfectly, about as well as one can ask for, since a lot of people are tested at a point when they're asymptomatic. And we know that people are truly asymptomatic at the time of being tested, because in order to get a test at Kaiser, they have to fill in a survey about a detailed kind of symptoms history. And there's different routes of testing that they're sent to if they're symptomatic or asymptomatic. So we have a very sort of a good opportunity to at least know at the point of testing whether people have symptoms or don't have clinically notable symptoms. Symptoms are subsequently monitored in the electronic health record for everybody. If they go on to have an outpatient appointment, for instance, and it'll appear in the clinical notes, or if they're in any instance tested again and prompted to indicate whether they have had symptoms, at the time of their 2nd test, we can sort of see, at least, from these indications if symptoms subsequently occur after an initial asymptomatic test. And what we can see when we do an analysis, again, using Cox proportional hazards model, adjusting for the same factors, demographics, infection history, vaccination, as mentioned before, there's a 30% reduction in risk of new symptoms onset associated with Omicron variant infection as compared to Delta variant infection for people who are tested first at a point of being asymptomatic. So, the estimates I've showed earlier on this basis could be considered underestimates of the extent of a true difference in severity for Omicron and Delta variant infections, insofar as much of this difference actually arises before the point of an outpatient test for most people, since most of those are occurring with symptoms. There's a very interesting group included in these analyses of people who were tested first in the hospital. And I say that they're very interesting because we have the best, follow-up of new symptom onset in this group, since they're being monitored regularly with interactions with healthcare providers. They're, a captive population for assessing new onset symptoms. And here, what we can see, although it's a small group again, and it would be nice to analyze a bigger group, but it's just a small but rich and interesting group, that in this cohort, we can see a roughly 46% reduction in risk of new symptoms onset during the time of follow-up. So from the point of people who are truly, hospitalized with an incidental COVID diagnosis based on the fact that they're testing positive after being hospitalized for another cause without symptoms of any acute respiratory infection. Following them during their hospitalization, we see that Omicron is associated with an almost 50% reduction in risk of any symptoms becoming clinically manifest. Interesting things to know about severity are not only arising at the point of whether they go to hospital, but also what happens once they're there. And we've already seen some indications that there's reduction in severity beyond hospital presentation based on the fact that we have higher estimates of the risk reduction for ICU presentation and death as compared to hospital admission. This plays out another way when we look at the length of stay for people hospitalized after symptomatic COVID-19 admission, meaning people who are hospitalized with acute respiratory symptoms onset on or before the admission date. And this difference is really big. So although it's a smaller group to analyze, it's a really interesting one. When we compare the estimated durations of Omicron associated admissions with the estimated durations of Delta associated admissions, we see a median length of stay of about 1.5 days for Omicron versus almost 5 days for Delta. In fact, among people who had a complete hospitalization at the time that the data were ended for this analysis, 84% of Omicron cases had been discharged, even though Omicron cases were occurring later in the whole study than Delta cases on average. And this was true of only 31% of Delta cases being discharged in such a short period of time. On average, and the medians, the length of an Omicron associated stay was 3.5 days shorter than a Delta stay, which is a 70% reduction in essentially, hospital bed utilization per case beyond the reduction in risk of a case going to the hospital to begin with. And so this is all analyzed using a series of competing risk models, which look at multiple causes of an observation, occurring at a particular point in time. So whether people are being discharged alive or discharged dead, or to hospice, essentially, since those types of hospital stays have very different lengths and are, as outcomes competing risks with respect to one another. And then these also control, when fitting these types of models, we're addressing censoring and the fact that a lot of, hospital admissions were not complete at the time of analysis with either outcome observed. One sort of further note that goes along with this and is not particularly surprising in light of the data that were just presented is that here, when we compare the discharge dispositions among people who had completed hospitalizations at the time of data being analyzed, we see everyone with Omicron was sent home or to home-based healthcare, were perceived as being well enough to have this kind of outcome, and none were discharged against medical advice. Whereas with Delta, we saw 5% going to hospital, who died in hospital or were sent to hospice, and then a small proportion that were sent to other types of skilled care. Some descriptive differences between Omicron associated and Delta associated infections. We see that the age distribution is pretty remarkably different, which was, I think, one of the most surprising features to me. We see very clear concentration of Omicron cases in kind of the 20 to 29 and 30 to 39-year-old age brackets, and as compared to the Delta cases, a sort of bigger relative reduction in cases occurring at the very young or very old extremes of this distribution. It's interesting to see that Delta cases were actually almost flatly distributed from 0 to 45 years of age or so. And I think this in part also reflects that Omicron cases are occurring largely during the winter holiday, whereas Delta cases here included they were occurring throughout December, and this occurs, also a period when children were in school. There was established circulation of Delta variant in many schools and sort of more opportunity probably for exposure to Delta as compared to Omicron over the study period. This will be a very interesting thing, of course, to monitor over time as the epidemic has progressed, beyond the last 2 weeks of December that are summarized here. Nothing very different to note, and no significant differences in the age distribution of Omicron versus Delta cases arriving at hospital. beyond at least what's different in terms of their overall age distribution. As you would expect, Omicron variant is associated with immune evasion, reflected by both now evidence of differential vaccine effectiveness, but also at earlier points, both the higher mutation load in the S gene and also documented differences in neutralization for people who had previous infection or vaccination. Here we see that there is a greater preponderance of people with some form of immunity among the Omicron cases as compared to the Delta cases. So here looking at adjusted odds ratios, we see 4.5-fold higher prevalence of people with or higher odds of a documented prior infection among those who had an Omicron detection as compared to a Delta detection. This being, again, imperfect indicator of true infection history. We see among people with higher numbers of vaccine doses, as well as for better vaccines as compared to this is adenovirus vector Johnson & Johnson vaccine. People who have 1 or 2 doses are almost 2 and almost 4 times more concentrated in the Omicron group here. And then likewise, we see sort of a stepwise increase of better immunity with higher numbers of mRNA vaccine doses being more common among the Omicron group as compared to the Delta group. This holds as well when we define sort of better immunity by not only their vaccination history, but whether they have infection accompanying vaccination. And so essentially, any measure that you can make that shows stronger history of immunity, we see more concentration in the Omicron cases. The last kind of interesting thing to note here that I want to bring to attention is that the picture is pretty optimistic for vaccine protection against hospitalization. Of course, this has now been confirmed by some early vaccine effectiveness studies that have a true endpoint of whether people get hospitalized in association with whether they were vaccinated. But here we have the opportunity to actually look and distinguish the effect of vaccination on the natural history insofar as does vaccination reduce one's risk of progressing to a severe clinical endpoint of hospitalization after the point of diagnosis. And here we see that certainly seems to play out both for Omicron or S gene target failure associated cases, as well as Delta. So here we have adjusted hazards ratio for the outcome of symptomatic hospital admission following a positive test for both the Omicron group and the non-Omicron group or the Delta group, looking at an exposure of vaccine history. And we can see in every situation, history of vaccination is associated with a reduced risk of symptomatic hospital admission. This group is a very small group. I'll note this is, this is people who had a Johnson & Johnson initial vaccine, which was not prioritized in Kaiser for the most part, and then also got a booster with that same vaccine, which is at this point very uncommon. So this is a less encouraging finding, but also a strange group to analyze. So this, again, I think, confirms something that we were expecting to see and very happy to see in this study. You'll note that in addition to the fact that the estimate is not necessarily as big in the Omicron group as it is in the Delta group, insofar as their protection seems a little bit less good here against Omicron, we don't see a huge difference for the number of doses received corresponding to a stepwise further reduction in risk of hospital admission. And I think that it's important to also reflect here on the fact that where we see the greatest differences in protection associated with vaccination and having 1 dose, 2 doses more recently or further apart, or 3 doses total. A lot of that difference is really manifest in whether you have enough immunity to prevent any infection at all from occurring. And even with 1 dose of Johnson & Johnson, people have been pretty well protected against hospital admission. So I think that this is not necessarily a terribly surprising finding that the difference in protection associated with different vaccine series is not necessarily a huge impact on whether people are getting hospitalized at all, but rather more affecting whether they get infected at all, and in particular in these instances whether they're getting infected with Omicron versus with Delta. So I think that although this would be nice to see kind of a stepwise reduction in risk of hospitalization with the booster dose, here we're looking at a narrow part of the clinical course of when they essentially have symptoms already to go to the hospital. And the differences that you'd expect with the booster dose are probably more along the lines of something that would arise at the point of whether they get infected at all or whether they have a symptomatic infection or not. So that's the extent of data that I intend to show as part of this. As I mentioned before, we will be updating the study very soon with sort of the full picture of what's happened through December and January. And I can't figure out how I did this a different way, and now my bar is blocking me from stopping screen share. But I'm very happy to take questions since they haven't arisen yet.
So Joe, this is Art. Can you hear me?
Yep.
Very nice presentation. Excellent work, as always. Where do you stand on the notion, as I understand it in the newspapers, Israel has decided to proceed with a fourth dose of vaccine for large numbers of people?
Yeah, I think that that's a smart call. I was traveling I wanted to go on vacation and I was supposed to go to France. And then like 3 days in, we decided we had to do this analysis. So there went my vacation. I was just like working nonstop. But before I went, I got a fourth dose because I didn't want to get stuck in France. And if we are prioritizing the prevention of infection, which from all signs I can see we're still doing by wearing masks and telling people to isolate and do that stuff, then we should be using the best available resources to help us prevent infection, which would include fourth doses if we're concerned about sustaining the level of protection needed to prevent infection or reduce circulation in the community. And in fact, that's probably going to be one of our best ways of doing it. And prioritizing anything else over vaccination would seem a very questionable measure by my account if the goal is to prevent infections.
Thanks.
Joe?
You're on mute. You're on mute, John.
Thank you. Joe, this is John. Thank you for that presentation, and thank you and your colleagues for that really wonderful work. I wanted to ask a little bit more about the classification of hospitalized patients and how confident your group is that these are patients who were hospitalized with as opposed to for COVID or vice versa.
I mean, it's not a perfect classification, and I think that one of the limitations with any medical record data is discerning the true cause of a hospital admission. Even if you had for instance, if you were using a definition like the admitting diagnosis or discharge diagnosis or something like that, I mean, you could still have issues arising with overlap there. Symptoms onset is a rarer one to have access to. And I think that, hospitalization secondary to new onset symptoms are useful in part because it might reflect people who, is the first way of identifying whether someone was tested as a screening program or not as part of screening. Although, maybe symptoms associated with acute respiratory infection weren't really the particular thing that led them to go to the hospital. It might have also factored into the clinical decision to admit them for something else if they're concerned about progression of COVID-19, since a lot of the things that would send them to the hospital overlap with risk factors that would make COVID-19 particularly bad for the same patient. So I think there's no an ideal study for assessing what caused a hospitalization would be a huge case control study that just took people who were tested at the point of entry, since we do that for everybody, looked at whether they were positive or negative for SARS-CoV-2, counted for all the other potential entering diagnoses they could have had, and look at the attributable risk associated with a positive test or something. You can envision an ideal study. Nobody's going to do it anytime soon, and nobody has access to it at the point that you need to analyze data and define a clean endpoint for each patient. So I with that limitation in mind, I think that knowing that they had acute onset respiratory symptoms up to 14 days before or on the day of admission is about as good as we can ask for.
Thank you.
So Joe, hi. Can I ask a question?
Yeah,
Joe, he's Yong. I really like your presentation. It's a wonderful presentation. I just have maybe a question, maybe a little bit, beyond your scope. The scope of your work is. I understand it that in the world, the WHO approved, several additional vaccine other than the three have been approved by the FDA in this country, and so I think you wonderful study. I'm really interested about the vaccine part. The compared to the people that are infected and then also vaccinated. So can you comment about? I don't know whether there's any data available from WHO or from South Africa, and those people that are vaccinated by a different vaccine group. Do they have the similar results you have, or can you comment on that, or your study is the first one to really push beyond, the U.S. really talking about global picture about, the mixed infection of the Delta and the Omicron.
So I think the first study that came out from the UK had a comparative estimate. It was Nick Andrews' first author, and it was PHE that put it out on medRxiv in mid-December, which looked at 2 and 3 doses of both AstraZeneca and Pfizer-BioNTech vaccines. I'm not aware of whether there's a vaccine effectiveness estimate for Sinovac or really anything else at this point associated with Omicron in particular. I imagine that such data will come out, but I'm not aware of studies as of this point that have reported something there. But there have at least been estimates showing effectiveness of AstraZeneca as compared to Pfizer, and now also Kaiser Permanente has studies for both Moderna and for Pfizer in Southern California for true vaccine effectiveness, which is a little different from what we looked at here.
Any data coming from the vaccine manufactured by Chinese? I think they have been used in Africa as well as in Latin America, like Brazil.
I haven't seen enough yet, and Brazil also, which is a setting that has had good VE estimates in the past, but I haven't seen it yet. It's also just there's an onslaught of papers, and I don't read papers that are coming out anymore because I can't. So it's possible that's come out, but I haven't seen it.
Thank you.
Joe, this is Art. I haven't seen papers that speak to this, but there is an op-ed in the New York Times this morning by my friend Dr. Osterholm and Zeke Emanuel that says that whichever vaccines are being used in China don't work against Omicron.
I would not be surprised because they don't work against anything else either, and Omicron's even more different. So I think that it's long past time to give those populations access to better vaccines.
There's a question in the chat from Ruan. Lovely presentation and fascinating data. Thanks, Joe. Were you able to look at the interaction between time since last dose, maybe for the 2 or fewer doses, and variant type on any of the endpoints? Curious about how the decay of immunity might impact severity by variant.
So we have not at this point, but it's definitely on the radar as something that we want to extend at least at the at the very minimum, so that we aren't presenting data for a 2-dose group as if they're a sort of unitary block of immune protection, since that is a very heterogeneous group. So uptake of boosters has been unfortunately low everywhere, but also in Kaiser it's not as high as one might have expected. Less than 25% of the cases that were analyzed here had any history of a booster dose, even among those with Omicron. And so we definitely will be presenting data stratified by time since the 2nd dose. And then it looks like Lisa's asked a question about fourth doses. I agree. You know, at some point, you know, it'll be very hard to get everyone, you know, say now it's time for your fourth dose, now it's time for your fifth dose. And I think a updated and going forward sustainable definition of you know, SARS-CoV-2 vaccine status is probably going to be, you know, have you been vaccinated within the season? You know, like we do for flu, like we do for you know, tetanus. It's not a season, but you know, we say that, you know, it's a 5-year or something interval between, or 10 years, maybe it's 10 years. I don't even know. I don't know if I'm up to date, but you know, we have vaccines where we have a definition of up to date that you know, accounts for, you know, that people should receive them on a regular basis. And I think that that's, you know, the future we're moving towards here as well.
Hi, thank you so much for your presentation and the data that you presented. So this data is all very reassuring that Omicron is a weaker variant compared to Delta. What is your speculation that if we have another mutant or variant, will it be weaker? Will it be stronger? Have you hypothesized that or thought about it?
My very rude response to this is that I think that SARS-CoV-2 is finally the death in the you know, the nail in the coffin of the idea that that viruses evolve to become less virulent in a deterministic way, or that, you know, with enough time we should expect to see everything become less severe infection. This is, you know, kind of always been known to be not true with myxomatosis and other examples. However, I think now we can, you know, remove that assumption as a you know, starting premise that everything will evolve to become less severe. I don't think it's really super possible to speculate on that. I think what, you know, turned out to be very useful for Omicron in terms of its transmissibility in the population was a better attachment in the upper respiratory tract, which is probably more relevant to transmission than attachment in the lower respiratory tract. Although we don't, you know, totally know the exact mechanisms that account for better transmissibility yet. And, you know, that was, of course, here also fortunate insofar as it is not associated with as severe a respiratory disease. However, you know, whether the same, you know, I think there's the constellation of things that can happen, and I would be very likely to be proven wrong if I said, you know, any direction of how things should go. I think, you know, the good thing is that immunity is protective, and we are a lot more immune now after Omicron infected about 30 or 40% of the country than we were before. Although it would be better for all of that immunity coming through vaccination, of course.
Thank you. There's two other questions, one from Jack. A number of estimates there were changes between the adjusted and unadjusted estimates, likely due to residual confounding, I assume. Do you have a sense of the most common confounders causing this?
The most common confounder is vaccination status, because there is a marked difference in vaccination status between Omicron and non-Omicron infections. So that is really the big one. And also because we see that vaccine, even for Omicron, is protective against hospital admission. But there are others too. I mean, the age groups, we had, you know, a less of a concentration of Omicron cases in the oldest age groups, for instance, than was observed with Delta. So there are several factors. One other interesting thing was is that we saw in the terms of the communities that Omicron hit first, it was now I'm going to struggle. So there was a difference by race and ethnicity and by socioeconomic profile of the communities. So people were more likely to have an Omicron variant infection if they were anything except white. Although that's, you know, 75% of the case population in this analysis, and, you know, we're looking at not, you know, the full income spectrum, but people who are members of Kaiser. So, you know, ethnicity and race is a little bit different to interpret here. We also saw that people who were tested and who found to be infected, who were Black or Hispanic, were more likely to progress to the hospital or progress sooner to the hospital than people who were tested and found to be infected in other groups. So there is some you know, difference that arises at those stages. That'll be interesting to see now that Omicron just, you know, became everywhere, and it's not really this community has Omicron, this community doesn't. It'll be interesting to see if that kind of stuff plays out with the full period of the outbreak and not just the first 2 weeks.
Thank you. One more question. Did you look at any data on reinfection with Omicron?
Not really a whole lot of data to look at yet, just because we are still at a point when no standard epidemiologic case definitions for reinfection would apply, since we usually use at least 60 days, but in some cases as much as 90 days of time between a positive PCR result and another positive PCR result to define reinfection. So I think there's more to learn there that we can't learn yet.
Any other questions? We have a couple minutes left. Well, thank you very, very much for such an informative presentation. We really appreciate it. And it's great work and great to hear about the data. So thank you very much.
Thank you for having me, and thanks everyone for questions.
And thanks everyone for joining. Take care. Have a good week.